Welcome, everybody. It's great to see so many people here joining us this evening, and for all of those that are watching virtually, welcome as well. We have an exciting program here today. It's urology clinical consults in bladder cancer cases from the community and expert guidance on translating the latest therapeutic advances into patient care from the various stages of bladder cancer, early to advanced. So of course, we have excellent panelists here on the stage with me, Matt Galsky, Janica Kurja, and I'll tell you a little bit more about them in a minute. But I do want to take a moment to thank the Medical Learning Institute, PeerView, and especially the Bladder Cancer Advocacy Network that has done a lot of pioneering work in helping raise awareness for our bladder cancer patients when it comes to bladder cancer. And of course, for our unrestricted educational support from AstraZeneca, Bristol Myers Squibb, Janssen, and Merck and Company, of course. As mentioned, if you haven't completed the survey, please do so. It really helps us improve the programs. Look out for the polling questions, and if you have questions, submit them. I have the iPad over here. I'll address them either as I get them or at the end, depending on what's appropriate, but don't wait till the end to send in your questions. Just type them in and send them over. You can visit PeerView at this address. If you want to take a screenshot, save it. And of course, if you need more information afterwards, there's the email at the bottom. There's the Twitter address as well for those of you that do social media and follow us on Twitter. So I'm going to start off a little bit with the introduction to the session per se. I'm Ashish Kamat. I'm professor of urologic oncology at MD Anderson Cancer Center. And why are we here today, right? So the question is, why do we all gather here today? Well, there's several gaps in our knowledge and also gaps in our application of treatments for patients with bladder cancer. Only 1/3 of patients with non-muscle invasive bladder cancer actually in the United States get intravesical BCG. Part of it is due to the BCG shortage, but also part of it is because of lack of understanding of the appropriate patient that should be getting immunotherapy with BCG. So we're going to address some of the unmet needs in non-muscle invasive bladder cancer. Dr. Kurja is going to talk to you about innovative therapeutic solutions. It's not that much better when it comes to muscle invasive bladder cancer. Close to half of the patients with muscle invasive bladder cancer don't get curative therapy. They're not offered radical cystectomy nor radiation therapy. And patients who really are undergoing radical cystectomy, half of those don't even get neoadjuvant chemotherapy. So really there's a lack of good quality care. And we need to reshape the treatment algorithms for our patients with muscle invasive bladder cancer. And of course, we'll hear about that from Dr. Galsky. And of course, there's been an explosion in immunotherapy and different regimens for bladder cancer, and the post-immunotherapy treatment landscape tends to be a little confusing when it comes to what agent, what sequencing, what do we use, do we switch to another IO agent, do we do a completely targeted therapy? And of course, again, then we'll have a discussion and we'll hear more about that. Everyone knows this. I mean, this is the overview of the different disease states when it comes to bladder cancer. There are several things that we know, several things that we don't know, and we'll address that in today's session. And again, I just want to make another plug for Beacon. It's an excellent resource for everybody, not just patients. It is an excellent resource for healthcare providers, physicians, their caregivers. And again, if any of you haven't visited their website, I can't imagine anyone hasn't, but if you haven't, please do go visit. You can download practice aids and a lot of brochures that are useful for patients in your clinic. So first off, we're going to talk about non-muscle invasive bladder cancer. I wanted to set the stage a little bit as to what is the unmet need that we have in bladder cancer. Now, one of the biggest things that has faced or challenged us when it comes to management and understanding patients with non-muscle invasive bladder cancer is actually understanding what it means to have a so-called BCG failure. And for many years, the development of drugs and research in this field was stagnant simply because there were many different definitions. We had patients who got classified as being BCG refractory. They were classified as being BCG relapsing. Of course, intolerant was a little easy to understand. But the problem was when there were so many different definitions that were being thrown about, studies that were being designed, regulatory bodies didn't know what to do with it. So back in 2014, the AUA came together together with the FDA. The International Bladder Cancer Group came together with discussions with the FDA and proposed the BCG unresponsive definition, which was then adopted by the FDA in their guidance document that is now used as standard for industry to develop studies. So again, just two sentinel publications for reference. The FDA guidance document has that in there. So what is BCG unresponsive disease? Well, if a patient gets BCG and gets adequate BCG, so that's at least an induction course and one maintenance course, and for practical reasons, we do allow the patient for entry into clinical study to get 5 of the 6 and 2 of the 3 when it comes to the maintenance. If they get adequate BCG and then they meet the following criteria, he or she is classified as being BCG unresponsive. So with T1 high-grade disease, the first evaluation, if the patient has persistent T1 high-grade disease or new onset T1 high-grade disease, that does qualify as BCG unresponsive because that is extremely high risk for that patient. If the patient had CIS and the patient gets adequate BCG, is disease-free, and then recurs, that should be within 12 months of exposure to the last dose of BCG. So again, I got a lot of questions at the AUA here based on different podiums. It's not the start of the BCG, it's the end of the BCG. So it's the last exposure to BCG. And when it comes to recurrent papillary tumors, if it's high-grade TA or T1, that is within 6 months of that last exposure. Now, why is that timing important? Why is this 6 months, 12 months important? Why is this something that we recommended to the FDA? Follow me a little bit on this graphic here, because this sort of tries to explain why that timing is important. So if you look at and I did this exercise with Don Lamb's study from the year 2000, but you could do it from any real clinical trial. If you look, for example, at patients that have carcinoma in situ, in this study there were 278 patients that were randomized to BCG induction only or induction plus maintenance therapy. So after induction BCG, roughly 55–60% of patients will have a CR with induction BCG. In the arm where you do nothing else, but you just give time for the immunotherapy to work and the Th1, Th2 balance to kind of come to where it's optimal, the CR will go up from 58 to 69%. In the maintenance arm, just by giving 3 more weeks of BCG, the CR goes from 55 to 84%. So 64% of so-called failures at 3 months can be salvaged just by giving them adequate BCG. And in the past, we had a lot of clinical trials that came in at this 3-month mark. Patient had CIS, they gave him drug X, and then got a 40% response rate and said, aha, this drug works, and it's salvage therapy, when just giving the patient appropriate standard of care BCG would have salvaged 64% of these patients. So that's why that timing is really important. Now, of course, BCG unresponsive is a category of BCG failure, but the large group of patients, especially in North America because of the BCG shortage, are not able to get the full course or the adequate BCG that we call it. So recently, the International Bladder Cancer Group again has come forward and recommended to the FDA that we have well-defined disease states. And if a patient gets BCG and has recurrent disease but doesn't fall into that BCG unresponsive criteria, then the terminology that you should be looking for when you're looking at reports or clinical trials that are being reported out is BCG exposed, because the patient has had BCG but has not had enough BCG to be BCG unresponsive. And for those trials, absolutely need a control arm, because the control arm is more BCG, and as I showed you earlier, BCG itself can salvage about 65% of patients. So if you don't have a control arm, it's hard to know whether the therapy is making a difference or the BCG, which would have been standard of care, would have made enough of a difference. So let's now move on to a case as an example. So this is a classic bladder cancer case that we see in our clinics, a 65-year-old male with intermittent gross hematuria. Appropriate imaging, as you can see there, upper tracts are normal. You can see a mass in the bladder, pretty decent sized mass there. The EUA, examined under anesthesia, which is important, didn't show anything palpable, so that kind of gives you a clue that it's non-muscle invasive, even though it kind of looks fleshy and like it might be. On resection, this was T1 high grade, muscle was present, not involved. The patient appropriately underwent a repeat TURBT and had a discussion, cystectomy, BCG, elected to receive an induction course of BCG for 6 weeks. L standard of care. Unfortunately, at the 3-month time point, this patient had that image. I don't know if you can see it, but there's a tumor there. This was resected and showed a TA high-grade lesion with concomitant CIS. So this patient fits the criteria for BCG unresponsive disease. And Dr. Kukreja, if you could tell us what are the options today for patients with BCG unresponsive disease?
All right, thank you. So BCG unresponsive disease, I think, I would be remiss if I didn't discuss cystectomy, just because it has such a high cure rate. And when you talk to patients, what is the one treatment that could get me cancer-free and is most likely to have me cancer-free 2 years from now, 5 years from now, 10 years from now, it's still going to be cystectomy. Now, I think it's a risk versus benefit discussion, and clearly not all patients are interested in that. So the rest of the slide is really dedicated to what are patients, that are interested in bladder salvage therapy, what are their options? So this is all rounded, not specific numbers, but just for ease. So BCG reinduction, not really great data for this patient. 35% response rate. BCG plus interferon. This patient has CIS, and you see the little disclaimer over there to the side. Patients with CIS all over the board, all throughout this slide, everybody that has CIS, their response rates are worse than what's listed here. For most patients, the ballpark rate is somewhere between 20 to 30%, and that's really the best that we see for most stuff. Valrubicin, I have not personally treated a patient with that. When you tell them 7% at 2 years, the juice is not worth the squeeze for that. Pembrolizumab, new kid on the block here. It's good for some patients, especially patients that are starting to have a lot of toxicity from local intravesical therapy treatments. They're not able to tolerate BCG reinduction. They're not able to tolerate any of the chemos that are listed below. Pembrolizumab is definitely an option for them. But again, I'll talk about it in a little bit more. The CIS response rate of 20% for a younger patient can seem somewhat bleak. And I've kind of divided this slide into FDA approved and not FDA approved. I mean, the chemotherapies, we're not going to be going to the FDA to have those approved. I'm going to expand on mitomycin and gemcitabine and docetaxel, probably the more promising therapies that we have. And then for various reasons, vicinium and nadofaragene are not available in the clinic right now. So I think their stories are still yet to be told, but they're both out there, and they both do have adequate response rates for stuff that we would definitely try to give patients if they become available. So a little bit about intravesical chemotherapy. So gemcitabine with mitomycin, the recurrence-free survival is very similar to gemcitabine docetaxel. And then much like the BCG, the maintenance matters. So if you look under there with maintenance for gemcitabine docetaxel, 81% 1-year recurrence-free survival for bladder cancer, that's really great. And the same with 2 years with maintenance, 59%. That's really great also. But what are the downsides to the gemcitabine and docetaxel as an option? So again, those patients with CIS are kind of outliers in their response rates. And I do think that there are plenty of urologists out there that have access to the gemcitabine docetaxel combination that are using this upfront if they don't have any BCG available to patients. I cannot underscore the importance of BCG availability and how that really impacts patients' decisions on how we manage their bladder cancer with them. But again, for just high-grade disease, really great response rates. So a little bit about Keynote 057. So this was a cohort of patients that were high-risk non-muscle invasive bladder cancer. There was 2 cohorts, one CIS and one without CIS, and they went on to get pembrolizumab, 200 milligrams every 3 weeks. It's kind of been changed now. Patients that are doing well can go to every 6 weeks, so a little bit less burdensome. And then if they did well, they didn't have a recurrence, they didn't progress, they went on for 24 months of treatment, and then they came off treatment and continued usual surveillance. Primary endpoints for this study were complete response in cohort A, so with CIS, and this is the backbone of how the FDA approved this drug for patients with CIS. It was approved in January 2020, and I think really permeated urology quite a bit really quickly. Whether it was people really looking for stuff to treat non-muscle invasive bladder cancer outside of the bladder, or whether it was just time for a systemic therapy, I would say urologists and medical oncologists picked this up really quickly. Um, so what were the actual numbers here? So for patients, 96 of the patients, 39 achieved a complete response at the first disease assessment, which was at 3 months. And then of the responders, it seemed like patients that responded continued to respond for a fair amount of them, almost a third of them. And then just to mention, the other side of the coin, I don't want to be all one-sided here. The SWOG S1605 trial did close early, and that was looking at atezolizumab with a couple treatment-related fatalities. Things that have been mentioned here, durvalumab, and I'll talk a little bit more about that later. One of my co-fellows, Roger Lee, presented this with durvalumab monotherapy. Again, I would say that a lot of us would think a complete response rate of 12% at 6 months is not hitting the mark quite yet. But there is some other data that was presented today at the SUO, the CG0070 trial with or without pembrolizumab, also another oncolytic virus technique that I think is going to be really exciting to see what happens in the future. So other upcoming trials, so Dr. Kamat mentioned the BCG exposed, and what are those patients? So this Keynote 676, BCG induction therapy only, so no maintenance whatsoever, and then randomizing them to a BCG reinduction or BCG reinduction with pembrolizumab, with a primary endpoint in carcinoma in situ patients, with complete response. And so I think you'll see as these trials are being designed with the FDA guidance, really the marker of response has been CIS. Do these patients respond to CIS? I see. Sorry. Excuse me. So some other slides, other things on this slide. So other things that are being tested in this same fashion, nivolumab and durvalumab. The ADAPT trial, very interesting, durvalumab with radiation therapy. And then in the BCG naive trial, I don't think we have enough trials in this area. So this is the outline of the Potomac trial. So BCG induction plus maintenance, BCG induction maintenance plus durvalumab, and then BCG induction only plus durvalumab. I think these are really interesting trials for a couple reasons. So the first reason, the BCG continues to be on a shortage, and while we're going through this BCG shortage and we don't really have an end in sight right now, if we could only give patients induction and then we give them durvalumab, which we have plenty of, and that's just as good as BCG induction plus maintenance for 24 months, well, that makes a lot of sense, especially for patients that can get the durvalumab. And then other similar trials in this area, Alban looking at atezolizumab and Crest looking at sansalimab. There's lots of ibimab, so excuse me for my ibimab not pronunciation correctly. So there is these trials. There we go. So what happens when you give people immunotherapy? And I think, as urologists, we really have not, as a group, delved into this, but I think if we start seeing durvalumab and other agents coming up in early on phases of treatment, I do think you will see more urologists starting to administer these medications. And there are definitely some large group practices out there that are doing it right now. So what are the things we look for? What are the bad things that can happen, the other side of the coin to immunotherapy? So GI related side effects, colitis, I think, is a really big one. I think when immunotherapy first started being administered, that was something that kind of got missed a fair amount, and there was some treatment related deaths too. But now we're very well aware of it, as we are hepatitis, pulmonary pneumonitis. You can also get a fairly significant myocarditis when we're talking about the cardiovascular system. Um, Derm stuff, the rashes, those are real. But I think most patients, they're pretty easily treatable, usually don't cause treatment delays. And then endocrine, thyroid problems are very common, diabetes. And then what do we do when we get these adverse events? So this is just a strategy recommended for managing immunotherapy adverse events. Grade 1, just continue therapy. And I mean, there's a lot of grade 1s. Most of them are, rashes, I feel tired, that type of stuff. Those are pretty easy. The grade 2 stuff, withhold, and then steroids if it doesn't resolve. And then 3, 4, much more serious, discontinue immunotherapy, hospitalization for IV steroids, tapering, all that stuff. And I think when we start talking about grade 3, 4 toxicities, that's where urologists, I think, have some learning to do. And if we're going to bring that into our practice, something that we really need to start to be comfortable with.
So thank you so much, Janet. That was a really succinct, summary of all the data that we have right now. There's a lot of work going on, and even at the AUA here, a lot of great abstracts being presented. A couple questions that come in, and let me start by asking you this one. The first is, in your daily practice and what you're actually doing in your day-to-day management of bladder cancer patients, how often do you go with cystectomy versus trying one of these bladder-sparing options for a patient, who's exactly like our case?
Yeah, I mean, I think I present most patients with all options, BCG versus cystectomy up front, and especially at recurrence, talking more about cystectomy. Generally, my practice is I don't really let people go past like 2 therapies. So like if they do BCG, then gemcitabine docetaxel. If they don't respond to that, then usually it's probably time to say, if you're healthy enough, cystectomy is the way to go. But I don't think we know. And I think the interesting thing about pembrolizumab specifically is, and something that I talk to my medical oncologists about all the time, is it preventing progression of disease. So while CIS is still in the bladder, is it preventing that CIS from becoming muscle invasive and metastasizing? And I don't think we know the answer to any of that. But in my day-to-day practice, I do offer cystectomy up front quite frequently.
So speaking of medical oncologists, I don't think there's anyone that knows more about bladder cancer than the gentleman sitting to your left over there. So Matt, let me ask you, and let me paraphrase a question, but ask you as well. So in a patient that has BCG unresponsive disease and is being considered for immunotherapy, right? What do you tell the patients about the data with pembrolizumab and how it compares to what you know about IO agents in general in more advanced states?
So I think that last point is the key one. So, I think there's a lot of sometimes surprise that the durable complete responses with Pembro in non-muscle invasive disease are what they are, but it completely lines up with what we see in advanced disease and muscle invasive disease too. The confidence intervals are pretty wide around response rates that range from 20 to 40%. You see that across all disease states. So I think there's a subset of patients that benefit a lot from these drugs, and it's a matter of finding out who those are.
Right. I think that's an important point because, in academic centers such as ours, we collaborate really closely with our medical oncologists and, we do it all together. But I know there are colleagues and friends that in the community that want to incorporate IO into their practice, which is great. But the nurses, the residents, the fellows need to know that the adverse events are quite different and can be deadly. It's not just a walk in the park for these patients. A question for you, Dr. Kokaria. This is more of a how do you do it kind of thing. Do you always prefer to do a repeat resection before you start BCG, or will you wait for a patient after they get induction BCG and then do a resection for T1 high grade?
For T1 high grade, I usually do it about somewhere 2 to 3 weeks after the initial resection, so I'm not delaying their start to BCG. So most of them will still start BCG within 4 to 6 weeks from their initial resection. but I do it before I start the BCG induction.
That's generally what we have in the guidelines, is to do a repeat resection for patients with T1 high-grade disease, especially if there's no muscle present in the specimen, because the risk of these patients actually having T2 disease that you then treat with BCG is fairly high. One last question before we move on to the next thing. And Matt, maybe I could ask this to you, even though it's a urology question. The question is, if I, a urologist, am trying to start this in my urology clinic using pembrolizumab, how or what's the best way to go about training my staff?
I think the key is to assume everything that a patient reports is a side effect of the drug until proven otherwise. And I can't stress that enough, because we tell our patients that, and of course they're going through a lot. They only retain a little bit of what we say because they're thinking about their disease and what's going to happen to them. And so it's not unusual for someone to come in a month later and say, oh yeah, I've been having diarrhea for 3 weeks. Even though we drill that into them. So if that's happening on the patient side, then it's definitely going to happen on the side of the folks who are getting calls from patients and saying, oh, diarrhea, take some Imodium or something like that. So just be vigilant that everything that a patient reports is related to drug until proven otherwise. It might not be, but assume it is.
Right. Right, good point there. So this particular patient was counseled on cystectomy, counseled on different options, elected to undergo intravesical therapy with gemcitabine and docetaxel. This is a regimen that has sort of become the de facto standard for BCG unresponsive patients, at least in North America. Got induction 6 weeks and was NED at that first evaluation. And just based on data that keeps coming out mainly from Mike O'Donnell's group, but also multi-institutional collaborative efforts, it appears that the maintenance therapy, which Dr. Kurkaja mentioned, is extremely important. So this patient is currently on monthly maintenance and has hit the 2-year mark and is NED. Please take a moment to answer some of the polling questions that you have on your iPad. They're not related to what we're going to talk about next, so I'll keep moving on in the interest of time, but just answer that as they come up on your iPads. So now we're going to talk about reshaping treatment algorithms for muscle-invasive bladder cancer, how to integrate what we know about multidisciplinary approaches and novel therapeutic regimens into our clinic. So for this, again, setting up the example with a case is always helpful. This is, again, a 64-year-old male with good performance status, ECOG 0, recently diagnosed with muscle-invasive bladder cancer T2. Examined anesthesia, clinical stage was done. It's not T3, it's not T4, it's T2. GFR is 54. Patient has hypertension, normal cardiac function, and is on the biopsy sent by the urologist noted to have a PD-L1 high status. Now, this patient is very interested in just getting the cancer out and wants to schedule a radical cystectomy ASAP, not interested in hearing about trimodal therapy or any such thing. For this type of patient, Matt, if you could lead us through what are the cystectomy therapy options for our patients.
Sure thing. So good evening, everyone. So we know that systemic treatment for muscle-invasive bladder cancer does improve outcomes. We have 2 large randomized phase 3 studies that establish neoadjuvant cisplatin-based chemotherapy as beneficial in this disease state. And it's really been some time, actually, since we've had medical advances for the treatment of muscle-invasive bladder cancer since these trials were published. We're talking about decades. And so this is really an exciting time in muscle-invasive bladder cancer the past few years, where there's a number of new drugs entering the clinical trial landscape here. The SWOG study results are shown here. We talk about a modest improvement in outcomes sometimes related to neoadjuvant cisplatin-based chemotherapy, but it's a 2.6-year median overall survival benefit to patients who benefit from this treatment. That's not insignificant at all. So this is a standard treatment. It's underutilized. And we're going to talk about some new things in muscle-invasive disease, but really the first priority is that patients are receiving guideline-directed therapy with treatments that we know can be beneficial. But you can see here, even with neoadjuvant cisplatin-based chemotherapy and radical cystectomy, far too many of our patients are developing lethal metastatic recurrence. We need to do better than this, and we need to integrate new therapies into this disease state. In a logical place or a logical group of therapies to integrate into muscle-invasive bladder cancer are, of course, immune checkpoint inhibitors. We've been talking about this. Those were really the first drugs in the current generation of drugs that have been introduced into advanced bladder cancer that showed benefit, and that's the paradigm in oncology. We show drugs are safe and active in metastatic disease, and then we move them earlier where they might have an even bigger clinical impact. So there's been a number of studies looking at single agent or immune checkpoint blockade doublets in the neoadjuvant setting. And of course, the benefit of the neoadjuvant setting for drug development in muscle-invasive bladder cancer compared to metastatic disease is that we could do single-arm studies. You can't historically do single-arm studies in the adjuvant setting. That might be changing, but historically you couldn't do that because you would give a drug to someone in the adjuvant setting, their cancer wouldn't come back, and you wouldn't know if the drug worked or they didn't have micrometastatic disease in the first place. But in the neoadjuvant setting, there is an intermediate endpoint. You could measure whether or not that tumor is eradicated when patients are taken to surgery. And we know that that correlates with long-term outcomes on an independent patient level. We don't know if it's a trial level surrogate, but we know that it's an independent level surrogate or a patient level surrogate for improved outcomes. So when we see that, of course, it's good for patients. So a number of studies looking at single agent or immune checkpoint blockade doublets. You could see many of them listed here. They range in size. They range in whether or not they enrolled only patients who are quote unquote cisplatin ineligible, or they enrolled all comers with muscle invasive bladder cancer. But the take home here is the pathologic complete response rate. And you can see path CRs with single agent or doublet immune checkpoint blockade in the neoadjuvant setting that really are pretty similar to what we expect with cisplatin-based chemotherapy. So this has led to a lot of enthusiasm for moving immune checkpoint blockade into the neoadjuvant setting. There were studies that were done in single-arm phase 2 studies in patients who are cisplatin eligible as well. And of course, in this setting, most of the time, the studies seek to build upon the standard treatment. So cisplatin-based chemotherapy plus immune checkpoint blockade. And of course, these studies are moderate in size, single-arm. But I think what we're seeing here is fairly similar to what we were seeing in metastatic disease when you combine chemotherapy and immune checkpoint blockade in urothelial cancer, which is that you're probably seeing a little bit of improvement in outcomes. But if you compare the path CR rates on this slide compared to the last one, it's probably modest. And we see pretty good path CR rates, at least in phase 2 studies with immune checkpoint blockade alone. So all of these strategies are moving to the phase 3 setting, and there's really independent studies being run for patients who are cisplatin eligible, building on cisplatin-based chemotherapy, adding immune checkpoint blockade, and then cisplatin ineligible patients with single-agent immune checkpoint blockade or non-platinum doublets. Interestingly, all of these studies include giving neoadjuvant treatment and then for a period of time, adjuvant immune checkpoint blockade as well. We're going to talk about that a little bit more later. The new kid on the block in the metastatic setting are antibody drug conjugates. And enfortumab vedotin is an antibody drug conjugate I'll talk about a little bit more later. But I have this slide here because we actually have the first study results of a single agent antibody drug conjugate given in the neoadjuvant setting for cisplatin ineligible patients. Small sample size, but this was presented at ASCO GU. And you can see giving this single agent in a cohort of patients who historically would go straight to surgery resulted in a path CR rate of 36%. So this is promising data. There's combination studies with this drug in the neoadjuvant setting in the phase 3 setting right now. Dr. Kamat.
So thanks a lot, Matt, for putting that into perspective. Now, one of the things I wanted to ask you to share with our audience here is when we look at path CR rates for patients that are undergoing neoadjuvant therapy, chemotherapy, but also investigational agents, and then we have that data at the time of cystectomy, what's your sense as to how valid that is as a regulatory endpoint?
Of course, there are a few limitations, as everyone in the room knows. One limitation is that in this disease, as opposed to others like breast cancer or lung cancer, in this disease, we know that the surgical treatment, the biopsy, results in path-CR by itself. So there is a baseline path-CR rate in this disease that you don't see in other solid tumors. And so that's one consideration, particularly in the context of single-arm studies, because you don't know exactly what the novel therapy is contributing. Those path-CR rates are above what we would expect with TUR alone, but there's always that background to consider. The second point is this issue that can sometimes be confusing of a patient-level surrogate versus a trial-level surrogate. And a patient-level surrogate means that if the patient in front of you has a path-CR, then they're going to have a good outcome. A trial-level surrogate is a treatment regimen that results in a higher path-CR rate compared to a different treatment regimen, leads to improved survival in that group of patients. And it's sort of hard to wrap your head around those differences conceptually, but a trial-level surrogate and a patient-level surrogate aren't the same thing. And right now, we don't totally know if path-CR is a trial-level surrogate, which would be a regulatory endpoint.
Right, absolutely. So this particular patient was scheduled for radical cystectomy in Dr. Kukrage's office, listens to a podcast, and then calls her and says, I want to cancel surgery and I want to explore a bladder-sparing option. So, Janet, what would you tell this patient?
All right. So options for bladder-sparing therapy, and I'm just going to say this right off the bat. So for patients that don't want cystectomy or cannot have cystectomy, chemoradiation is the standard of care. And what does that mean? So it means radiation alone is not the standard of care and chemotherapy alone is not the standard of care. It's the two of those together. Not the chemoradiation is the standard of care for all bladder cancers. No, it's the combination together are what should be used in patients not getting cystectomy. And this is based on a phase 3 trial, muscle-invasive bladder cancer, and they looked at, and you can actually see over here on the right-hand side of the slide that the radiotherapy is in the red line and the chemotherapy is in the blue line, and both, thank you, Dr. Kamat, both of them have inferior overall survival and disease-free survival at 72 months. So what are some of the disadvantages? So some patients cannot receive chemotherapy, and I don't want to talk out of turn or talk out of school here with Dr. Galsky next to me, but I would say that often there are options for patients for chemosensitizers. Maybe they're not getting full cisplatin-based chemotherapy, but there's many different ways, gemcitabine, 5-FU, mitomycin, all sorts of things that can be used as chemosensitizers. And so I would say if a patient cannot get a chemosensitizer, I really think that evaluating just getting radiation alone for anything other than symptoms is something that maybe a palliative care consult or something like that should be considered. And I think radiation for symptoms is a totally different beast than chemoradiation for when we're looking at disease-free survival and overall survival. So here's some clinical trials in this space. So this is a phase 2 Pembro plus gemcitabine and the concurrent hypofractionated radiation. So this does not have any node-positive patients, but muscle-invasive bladder cancer, patients that are cystectomy ineligible or they want bladder preservation. They can't have had any previous chemo. And they got Pembrolizumab prior to maximal TURBT. Some of the studies are being designed this way so that the immunotherapy is given while there's some primary tumor probably still in place. Patient goes on to get maximal TURBT, they get radiation, they get gemcitabine, and then they get pembrolizumab, and then 12 weeks they get post-radiation therapy TURBT. And anybody that has seen these post-radiation bladders knows that a TURBT is really what you need to know if there's disease there. Most of the time you cannot tell just looking at it whether there is still tumor there. So the follow-up to this, so at a median follow-up of almost 15 months, the patients with bladder intact, disease-free survival was 88%. Some immune-related toxicities. And then you can see over here on the right-hand side, the probability of recurrence or death. So either event makes a tick down in that. So really, pretty good, drops below 80%, but still very good when we're talking about bladder preservation. Some other randomized trials that are still going on. Keynote 992, S1806, and Inspire all kind of use some variations of this almost very similar trial design. So very exciting things to come for patients that are preferring bladder preservation. So this is durvalumab with concurrent radiation. So this is looking at patients that are getting TUR, durvalumab, and then they go on to get radiation, and then again a TUR for response. This is an abstract that was presented at ASCO last year. And what they found was, again, very similar, that around 80% of patients had a response. And the bladder intact, similar, 73%. Interestingly, kind of what we talked about a little bit earlier, there was a 31% of the grade 3-4 events. So those can be very significant when you're trying to complete a 1-year or even 2-year course. And it's something that we're really interested in pursuing. We really have to take everything seriously, as Dr. Galsky said. So this is a novel approach to both non-muscle and muscle invasive bladder cancer, but this is a particular clinical trial looking at patients with muscle invasive bladder cancer. It's with something called TAR-200, and if you haven't heard of it, it's essentially a thing that you put in the bladder, and then it coils up like a pretzel, and then it has a sustained release of gemcitabine. Now, the matrix can be impregnated with all sorts of stuff, but this particular trial was looking at gemcitabine. And this was really a phase 1 safety trial. And it, again, with the pathologic downstaging and the pathologic complete responses, partial responses, kind of take with a grain of salt, because again, we know that TURBT definitely contributes a fair amount, but actually a pretty exciting method of drug delivery. And here are the results from that. So it was pretty well tolerated. The main side effects, as you would expect, were lower urinary tract symptoms. And then if you look to the right, just a ton of combination trials over here on the side, looking at a newer agent, citralumab, with the TAR-200, and then one with the TAR-200 versus concurrent chemoradiation. So a complicated trial scheme, honestly, but Sunrise, I think, is a really interesting way to incorporate the TAR-200. So then this last slide here, also an abstract presented at ASCO. This is looking at patients with TURBT and chemoimmunotherapy alone for muscle-invasive bladder cancer, so patients not getting radiation therapy. And so we've heard a lot about these trials. Patients, if they have a complete response to chemotherapy, if they have a complete response to some of these triplet, doublet therapies. So this particular trial, gemcitabine plus cisplatin plus nivolumab, preserving the bladder and not doing radiation and not doing cystectomy. So you can see actually a fairly 50-50 split for patients that did respond. So 30 of the patients had a clinical complete response, and then 33 had not a clinical complete response. And then I think the really interesting thing to me is patients that had a clinical complete response. If you look at the swimmer plot over here on the right, you'll see that all the patients in blue had local recurrences. And I don't know if you can pull it out there, but there's green dots on those too. So there were still plenty of patients that underwent cystectomy. And I think the trial data on this, as far as metastasis-free survival and stuff like that, is still pending. The overall idea, though, is that you can pick patients that are going to be complete responders to whatever it is, and then you can preserve their bladder and then follow them safely. So I think overall, a complete response rate of 50% is awesome, and 50% of those patients got to keep their bladder. And if we can predict those patients ahead of time and do it safely, I think this will quickly become a standard of care and redesign the muscle-invasive bladder cancer pathway completely.
Okay, so on our iPad, you have this poll coming up. Please answer that. Reassessing your understanding of bladder-sparing approaches, including TMT and intravesical devices for patients with non-muscle invasive bladder cancer or muscle invasive bladder cancer. Those are your options. So please go ahead and answer that while we're listening to some background music, I'm sure. While you guys are answering the poll, let me ask a question to you, Matt. Looking at the DDR mutations and their ability to sort of help us guide who is or not going to respond to cytotoxic therapy, where are we today?
So the data has been pretty mixed. Lots of data suggesting that certain DNA damage response gene alterations predict sensitivity to cisplatin-based chemotherapy. Mechanistically, that makes sense. The problem is that there are a bunch of genes that are called DNA damage response genes. Some of those mutations have been characterized. Some of those mutations have been made, introduced into cell lines where mechanistically they've been proven to be sensitive to platinums. In others, we just see on a genomic sequencing report and we say, hey, that looks like it's probably going to be a pathogenic alteration. So I think the problem is that it's completely across the board. The best data is for ERCC2, but even that hasn't been totally consistent. So not ready for prime time.
Yeah, no, good point there. We've had trimodal therapy as an option for patients for decades now, right? It just hasn't caught on, at least in North America, with any sort of reliability. It's used more in the UK, for example, also in maybe a few cities in the United States. I think with the advent of the IO-based TMT trials, there's a resurgence in interest in bladder-sparing approaches, which I think is great for our patients because there certainly is a role to play. But a word of caution, when we look at clinical response rates prior to cystectomy or after chemotherapy with cystoscopy and biopsy, we as in urologists are wrong more than half the time, right? Because on cystectomy, we'll find residual disease in the bladder, even if your cystoscopy and biopsies suggest that there's no evidence of disease. So it's one of those things that we have to watch really carefully as we're moving forward. So this is just the results of your poll based on what you answered, and you could see those on your slides as well. That's interesting. So now this patient undergoes radical cystectomy, gets chemotherapy, undergoes radical cystectomy, and has T3B disease. Again, classic type of presentation. The chemotherapy is 4 cycles for this 46-year-old lady who had muscle-invasive bladder cancer, 4 cycles of Gemcis, undergoes radical cystectomy, elects to have a neobladder, and the pathology comes up as T3B. The nodes are all negative, 38 were sampled, and they were all negative. So for this patient, where are we today? We've heard about adjuvant therapy for many years. It's been discounted when it comes to adjuvant chemotherapy. Where are we today, Matt? And if you could also talk to us, where would we be today in the clinic if this patient had, frankly, node-positive disease?
So this is where some of the most exciting data has been in the past year in muscle-invasive and advanced bladder cancer, and that is related to trials that have integrated immune checkpoint blockade in the adjuvant setting. So we have 3 trials that were designed pretty similarly with a few nuances. Patients were enrolled. So we talk about these as adjuvant MIBC trials, but they're actually different than the adjuvant trials that were designed previously. They're actually different patient populations. So we shouldn't think about comparing these to those trials of the past few decades with adjuvant platinum-based chemotherapy. The reason that they're different is that these trials enrolled patients who had neoadjuvant chemotherapy and had residual disease, or patients who didn't have neoadjuvant chemotherapy, had high-risk features, but were cisplatin ineligible. So 2 major unmet need populations. The endpoints of these studies were disease-free survival, except for Ambassador, which is the one study that hasn't read out yet, has a co-primary endpoint of overall survival. So this is IMvigor10. This study compared adjuvant atezolizumab, a PD-L1 inhibitor, with observation in that patient population that I just mentioned. And unfortunately, this study didn't meet its primary endpoint. This data set, though, has really been important in terms of us thinking about the future. And it's been important because what the investigators did on this study was they had this pre-planned, but it was a retrospective analysis. They took specimens, plasma from patients on cycle 1, day 1 of treatment, and they looked for circulating tumor DNA. And if circulating tumor DNA was present, they asked the question, would that have made a difference in the study if we selected patients who were at highest risk for micrometastatic disease? And that analysis indeed showed if you reanalyzed the study and limited the analysis to patients with circulating tumor DNA that was detectable on cycle 1, day 1, it actually did show a benefit with adjuvant atezolizumab. It's exploratory, but it's certainly important in terms of how we think about designing studies for the future. On the flip side, the Checkmate 274 study has been practice changing. In this study, randomized patients between nivolumab and placebo, so not observation, but placebo. The primary endpoint was disease-free survival in the intent to treat population, so in all comers. And then there was a co-primary endpoint of disease-free survival in patients with high PD-L1 expression in their tumor. You can see both analyses here. In the intent to treat population, nivolumab was associated with an improvement in disease-free survival with a hazard ratio of 0.7, and these data are actually updated at this meeting, so a minimum follow-up of 11 months. And you can see in the patients with tumor PD-L1 expression greater than or equal to 1%, a hazard ratio of 0.53 in favor of adjuvant nivolumab. Importantly, the safety of nivolumab in this patient population is very much what we see in patients in other disease states like metastatic disease. So these drugs are not without potential side effects. We've already heard about that today. But the side effects in this patient population are not different than we see in other patient populations. Importantly, so we talked about the patient population enrolled here, and think about it for a second. These are patients who already went through 3 months of cisplatin-based chemotherapy and then had their bladders out. And so if you're going to give a drug in the adjuvant setting, it's got to be something that's tolerable because patients have been through a lot at that point. For the patients who hadn't received neoadjuvant therapy, they were cisplatin ineligible, and that's usually accompanied by some comorbidities. So to think about giving additional treatment at that point, it's got to be well tolerated. And you can see here quality of life in the intent to treat population and the subset of patients with PD-L1 high expressing tumors, and there was no difference in quality of life in patients getting a year of Nevo versus a year of placebo. Very important data. Dr. Kamat.
So, for that particular patient, historically, we would do observation, right? If somebody had T3B disease after chemotherapy, what do you think is the current status, or what should be the current status of Nevo based on Checkmate 274? We have disease-free survival, but we don't have overall survival. This patient is young, healthy, very active. What would you advise this patient in your clinic?
So a 46-year-old patient with T3B disease after neoadjuvant chemotherapy, I am recommending that patient gets adjuvant immune checkpoint blockade. Of course, we have a balanced discussion about the risks and benefits, but we don't have survival data from it yet. But if you err on the side that there might be an improvement in someone who's this young with high-risk disease, I think it's important to discuss.
And let's assume that this patient hadn't received chemotherapy, was understage, thought to be T2, and then ended up being T3B. No chemotherapy, though. Would you still discuss and offer Nevo?
Yeah, I certainly still discuss it, particularly if a patient's cisplatin ineligible, and that would be consistent with the eligibility criteria for the study. I don't know what you would generally quote a patient in terms of the risk of metastatic recurrence in that setting, 40%, something like that, and so it's not nothing.
What about that patient watching closely, says, I'll come to your office, I'll be surveilled, actually doesn't even go to your clinic, seeing Dr. Kukreja, and says, I'm willing to come every 3 months and get scans. Dr. Kukreja, what would you tell that patient? Would you advise she goes to see your medical oncologist, or you say, I'll follow you, and if you have a recurrence, I'll treat you then?
I think it depends. So If she did not have any neoadjuvant chemotherapy, she's going to see the medical oncologist. If she chooses not to do anything, that's their choice. But usually I alternate follow-up every 3 months. So I see them 3 months, medical oncologist sees them next 3 months, then I see them 3 months after that. But in general, if they haven't had any chemotherapy in any patient that has T3B disease, I send them to medical oncology to talk about adjuvant chemo.
Okay, that's interesting because, in an informal sort of survey amongst medical oncologists, actually, in the US, it seemed like many were not sort of willing to offer Nevo just based on DFS, and then talking about the IMvigor10. Matt, could you explain or try to explain to the audience the difference between the two trials and why you think one read out positive?
Yeah, I mean, it's all hand waving in terms of the potential explanations. The trials were run independently, and the results are what they are. But I think a potential difference is that one study used observation as the control, and one used placebo as the control. And there is the potential risk for informative censoring in an adjuvant study that's an open label design where patients have high-risk disease. They don't enroll on that study because they want to get observation. They enroll on that study because they want to get treatment. So they enroll, they're randomized to observation, and then they drop out. And they're censored right at that point, so those events don't count. And if you look at the consort diagrams for the study, you see lots of patients dropped out in IMvigor10. We have a paper that was published a few days ago in Cancer simulating the percentage of patients that would have to have been censored at non-randomly censored for that study to have actually read out as showing a survival benefit, and it's not a ton. So I think that informative censoring is a potential explanation for the discrepancy between the two studies, but it's speculation.
Okay, that's interesting. Do you recall what the number of patients for the dropout?
14%.
14%. That's within that margin. A question's come up as to should Nevo be also offered to patients in the adjuvant setting for upper tract urothelial carcinoma? I presume your answer would be yes.
Yeah, my answer is yes. I mean, of course, that question is brought up because of the subgroup analyses. And if you look at the effect size for upper tract disease, smallish numbers, but if you look at the effect size, it certainly seems different than patients with tumors originating in the bladder. That coupled with the biological plausibility that there might be a difference, I think has fueled this concept of whether or not it's the right treatment for upper tract disease. The study was designed to ask this question in the entire patient population. The subgroup analyses are hypothesis generating. So in the absence of a better study with better treatment in that patient population, I'm generally offering it.
Okay. Well, again, this is a polling question. Assume that this patient we've been talking about actually did get 4 cycles of Gem-Cis and then had the radical cystectomy and it was T3B. How would you, and this is for the audience, manage this patient? Take a few seconds and answer that question. Did you choose the music?
I thought you chose
I
it.
did not.
I remember you making me listen to this in the OR.
Okay, that's good. Matt, people are listening to you.
All right.
Okay, so again, this is a summary slide talking about what we talked about. Numerous therapeutic advances recently when it comes to patients with metastatic disease. Translating these in the real world, of course, requires folks such as my panels here to put that into perspective so we can actually talk about it with our patients. It's important to remember, though, that when we're offering these different treatment options to our patients, not every patient is going to be cured. And especially in the metastatic setting, the patient will often see the urologist first, develop that relationship, and will often look to the urologist in the room for your guidance into what therapy he or she should get. when she goes to see our medical oncology colleagues that, will take care of them even though they have metastatic disease. And speaking of, now moving into the metastatic arena, again, a typical patient, 64-year-old male with symptomatic progression, back pain, presents and has a CT scan after 4 cycles of carbo-gem that's showing liver and bone metastases. Performance status is 1. The NGS of this primary bladder tumor tissue that was taken out was done and shows an Fgfr mutation. There's no real issues that would necessarily preclude your patient from getting any therapy of choice, other than, say, grade 1 neuropathy. What would the course of treatment for this patient be?
So lots of new treatments in the metastatic urothelial cancer setting. Despite all of the new treatments, really the standard treatment in terms of frontline is platinum-based chemotherapy. We've tried to replace it multiple times, but that's really the standard first-line treatment. We'll talk about some new therapies that have been used after platinum-based chemotherapy, but that really does remain the standard. So there have been a few different approaches to try and replace platinum-based chemotherapy. Some trials already completed, some ongoing. And these really involve strategies that had been used in other solid tumors, in many of which showed success in other solid tumors. In the story in urothelial cancer has been shaping up a little bit differently for reasons that aren't totally obvious. So the strategies have included giving chemotherapy with immune checkpoint blockade together. We'll talk a little bit about that. Giving immune checkpoint blockade doublet therapy, so not just giving a PD-1 or PD-L1 inhibitor, but giving that with a CTLA-4 inhibitor. Giving treatment with a novel drug and getting rid of the platinum entirely, and we'll talk about that a little bit more. And then this strategy, which is not used in any other solid tumor right now, that really is the one that's shown benefit in urothelial cancer, which is this concept of switch maintenance therapy. So when immune checkpoint inhibitors were initially approved for the treatment of metastatic urothelial cancer, they were first approved in patients who had received platinum-based chemotherapy and then progressed. In our standard approach to platinum-based chemotherapy, it is to give up to 6 cycles of treatment and then stop. And the reason that we stop is if you keep giving patients platinum-based chemotherapy, then the toxicity keeps escalating and the benefit plateaus. So 6 cycles is about when that happens. So that's usually historically why we've stopped at that point. But the vast majority of patients will then develop progression of disease at some point, sometimes only after 3 months by the time of that next scan. And so the logical question was, immune checkpoint blockade is non-cross resistant with chemotherapy. It has a different side effect profile. Why are we waiting for patients to develop recurrence? Why don't we just give it right after finishing platinum-based chemotherapy? And so that's the switch maintenance concept. And this has been studied in 2 randomized trials, a randomized phase 2 study, which was a little bit smaller with Pembrolizumab, and then our phase 3 study with avelumab. And here's the results with avelumab. This phase 3 study had overall survival as a primary endpoint. And you can see here that both in the intent to treat population and the patients with tumor with increased PD-L1 expression, that there was an improvement in overall survival. In the median improvement is actually about as large as we've seen in metastatic urothelial cancer trials, about a year in terms of a median improvement in survival. And so this has become a standard treatment strategy in urothelial cancer. Still, though, we're trying to get rid of platinum. And so now that chemotherapy plus immune checkpoint blockade so far hasn't been the answer, we've thought about integrating novel treatments into this setting. We know that single agent atezolizumab and pembrolizumab still probably do have some role in terms of upfront treatment, but right now that's probably limited to patients who can't get any chemotherapy. So can we develop a combination that doesn't have chemotherapy that really could compete with platinum-based chemotherapy? There are a few approaches, a few recent data sets. This one's hypothesis generating, but it's sort of interesting getting to your prior question, Dr. Kamat. So this was the Bayou study, and it was presented at ASCO GU. And what this study did was randomize patients between a PD-L1 inhibitor or a PD-L1 inhibitor plus olaparib, a PARP inhibitor. You're probably familiar with PARP inhibitors from the prostate cancer world. So this study was an all-comer study, and it didn't show a benefit in all comers, but then they had a secondary endpoint of looking at outcomes in patients with DNA damage response gene mutations, and you can see there seems to be some improvement in outcomes in that subset of patients. So unclear where this is going, but it's interesting. What's been potentially more impactful are combinations of antibody drug conjugates with immune checkpoint blockade, and we spoke about enfortumab vedotin earlier in the neoadjuvant setting in that single-arm phase 2 neoadjuvant study, but this drug has been much more extensively studied in the metastatic setting. So we have 2 antibody drug conjugates now approved for the treatment of urothelial cancer. One of them is enfortumab, and here the target is Nectin-4, very highly expressed in urothelial cancer. It has MMAE as the cytotoxic payload. This is a microtubule agent, sort of like a taxane, but is very, very potent. The drug can't be given if it's not conjugated because it's so potent. You need to deliver it specifically to cancer cells targeted with an antibody. And then Sassatisumab Govotican, this is directed against TROP2, also very highly expressed on epithelial cancers, and it has SN38 linked to it. This is like irinotecan, a drug that we use in other cancers like colon cancer. So these 2 ADCs are FDA approved for metastatic disease. Enfortumab vedotin is the only one that's been studied in the phase 3 setting in metastatic disease, and this trial enrolled patients who had already progressed despite platinum-based chemotherapy. Most of the patients had already had immune checkpoint blockade, and you can see here a survival benefit with enfortumab vedotin, sort of reinforcing the accelerated approval that had occurred earlier based on a response rate endpoint. The response rate with this drug in patients who already had platinum, already had immune checkpoint blockades, about 40%, which is pretty good compared to what we've seen with drugs historically in this space. And some of these responses are pretty durable as well. So that led to this concept, should we give enfortumab vedotin with an immune checkpoint inhibitor together? And this slide has been shown multiple times at different meetings since it was first shown at ESMO. And this is the waterfall plot for the combination of enfortumab vedotin and pembrolizumab in a smallish cohort of patients with metastatic urothelial cancer or cisplatin ineligible. And of course, the reason that it's been shown so much is this is probably the highest response rate that we've ever seen with a combination in metastatic urothelial cancer. Again, single-arm study, relatively small data set. We've been fooled before with phase 2 studies, but pretty impressive results. And this regimen has now been moved on to multiple phase 3 studies, including in the neoadjuvant setting and in the frontline setting, still trying to replace platinum-based chemotherapy. This is Sassatisumab Govotican, the other antibody drug conjugate. This drug has not yet been reported in a phase 3 study. A phase 3 study has been done, but it hasn't been reported yet. We know that this drug has activity similar to enfortumab vedotin. Maybe the response rate's a little bit less, maybe about the 30% range compared to the 40% range. Different side effect profile. And then there's a new group of antibody drug conjugates that are coming, and these are directed against HER2. HER2 has not been a great target in urothelial cancer. There have been a bunch of studies with small molecules targeting HER2. Trastuzumab hasn't been a great target so far, but these new studies seem to be a little bit different. It seems to be potentially a pretty good target to deliver cytotoxic therapy. So there's a drug called Trastuzumab Deruxtecan, which is FDA approved for the treatment of breast cancer, and this was studied in combination with immune checkpoint blockade in patients with urothelial cancer that had overexpression of HER2 on their tumor. And you can see here this combination results in a response rate that was 36%, but you could see that more patients than that had some regression of tumor. There's another antibody drug conjugate directed against HER2 that's actually been through a series of phase 2 studies in Asia. It's initially been developed in Asia, showing pretty impressive response rates, and that drug is now being developed in the United States as well. That's RC48. Erdafitinib is a small molecule inhibitor of mutant FGFR. We know that FGFR3 mutations, like the case that we've heard, those mutations are present in about 20 to 30% of patients with muscle-invasive urothelial cancer. And those mutations are activating for this receptor tyrosine kinase. So they activate the receptor, they turn on this light switch, which causes downstream signaling within that cell and causes growth and proliferation. And so blocking that active kinase with a small molecule, like we do in other cancers like lung cancer, seemed like a reasonable strategy. FGFR inhibitors entered the clinic, showed activity in urothelial cancer, and ultimately erdafitinib was approved. And you can see here the swimmer's lane plots with erdafitinib showing that for some patients, these responses are pretty durable. Patients could be on treatment a year or 2 years with this oral therapy. So the only oral targeted therapy that we have for the treatment of urothelial cancer. So again, the concept came up. This is a drug that has a different mechanism than immune checkpoint blockade, a different side effect profile. Should we give this with immune checkpoint blockade? So this is a small randomized study that was presented at ESMO comparing erdafitinib alone with erdafitinib plus citralumab, which is an immune checkpoint inhibitor. And you can see with the combination, the response rate was 68% versus 33% with erdafitinib alone. So another data set that seems to be demonstrating higher activity with a combination than with the single agent, and this regimen is moving forward for further evaluation. All of these drugs, all of these new drugs are associated with a whole host of new side effects that we have to learn about, a whole host of new specialists that we have to integrate into care. And so this has really been, there's a learning curve with each and every one of these approvals. Just very briefly, erdafitinib, this oral FGFR inhibitor, can cause some ocular toxicity, so you have to get the ophthalmologist involved. It can cause a rash. It could cause hyperphosphatemia, which is usually pretty well managed. It can cause skin and nail side effects that can actually be treatment limiting. Enfortumab vedotin, the antibody drug conjugate, can cause neuropathy. In a subset of patients, it causes hyperglycemia, even in patients who don't have pre-existing diabetes, and it can cause a rash, which can range from something that's just irritating to something that's quite serious. And then Sassatisumab Govotican, the antibody drug conjugate that has the irinotecan-like drug attached to it, has irinotecan-like side effects. So it can cause cytopenias and it can cause diarrhea. Dr. Kamat.
So, Matt, I mean, again, you did an excellent job summarizing a complicated topic for in a short time. But in a practical sense, if this patient essentially, is asking you, based on my tumor status, what should I essentially choose? Would you necessarily need to have the tumor sent out for analyses before you make treatment recommendations, or are you able to do that without that in place? That's number one. But the corollary really is, I guess I'm asking, when should people be sending out tissue for analyses?
So on paper, you wouldn't necessarily, because on paper, the next treatment for this patient is an immune checkpoint inhibitor. That said, there are some clues given in this case that make you want to really individualize that treatment decision. Clue number one is that A1C of 9.2%. So that's not a contraindication to give enfortumab vedotin, which we were saying can cause hyperglycemia, but you get a little bit nervous about it. You see that there's no pre-existing eye, skin, or nail toxicity. And the patient has an activating mutation in FGFR3, and they have liver and bone metastases. So none of those are absolute indicators that immune checkpoint blockade isn't going to work. It can still work in some patients, but liver metastases is usually associated with a lower likelihood of response. So with all of those features, I would really be thinking about erdafitinib for that patient.
And given the liver metastases, would you tend to lean towards EV if everything else was equal?
The data regarding erdafitinib in patients with liver metastases has not been presented in the same way as with enfortumab vedotin. In my experience, erdafitinib works quite well in patients with various sites of metastatic disease. So that will often sway my decision between immune checkpoint blockade and enfortumab vedotin. But in this patient, I wouldn't use that to influence my decision between erdafitinib and enfortumab.
Okay. Dr. Kukeja, you heard, about all these agents, EV and Sassatisumab Govotican and ERDA in the advanced stages, right? Where do you see them falling in earlier disease states?
Yeah, I think that's a good question. And especially with the EV neoadjuvant study that was presented at ASCO GU, I think all of these will find a home eventually. But I think something else that they talked about at ASCO GU pretty seriously is as you add these on, the toxicities add on. So really weighing benefits to the toxicities.
Yeah, and of course, for urologists, we like intravesical delivery of these agents because you can avoid some of the toxicity. So EV is actually being studied in a phase 1 trial. Only 3 patients so far enrolled, but at least in preclinical studies, it appears to be active. A couple of questions from the audience for you, Matt. First is, based on the switch maintenance data that you presented, what are your thoughts about substituting whatever IO is available rather than nivolumab?
The level 3 evidence is switch maintenance. The level 3 evidence is with avelumab, and that's really what's listed on guidelines. We have randomized phase 2 data with pembrolizumab. It's not FDA approved in that context. Because we have randomized data, personally, I feel comfortable using it, but that's not the board's question. That's not the board's answer to that question.
Right. Question for you, Dr. Kukeja. This is actually going back to non-muscle invasive bladder cancer. For a patient that has T1 high-grade bladder cancer that's BCG unresponsive and who just refuses a radical cystectomy, what is your preferred treatment option today?
Yeah, my preferred treatment option is the gemcitabine and docetaxel with maintenance. I think it's really well tolerated. If patients tolerate BCG, they tend to not have any problems with the gemcitabine docetaxel with like lower urinary tract symptoms or anything like that. It's also a completely different mechanism of how it works as opposed to BCG. So I think if a patient has a really quick recurrence, maybe hitting them with a different mechanism of trying to treat the tumor makes sense. It's also, pretty easily accessible for us because we're, spoiled and attached to a cancer center. So it works out really well for me, and that's usually my go-to. And I would say for a lot of urologists treating bladder cancer, that is their number one. That is what they're using in BCG unresponsive, and if they don't have BCG available.
Yeah, I think the results with that combination have been so good, and we have been forced to not have anything to offer our patients until Pembro was approved. That there's a lot of traction amongst that, and urologists have gotten comfortable. And of course, Pembro was approved on January 8, 2020, right before COVID hit. So the adoption in the community has been less with pembrolizumab than you would expect based on approval and a phase 2/3 study with the FDA. And GC is sort of the elephant in the room when you're looking at all these newer agents that are coming out. And I say, sorry, dosi, not GC. Matt, you've done a lot of work when it comes to FGFR mutations. I mean, we know that most of the mutations occur in the low-grade tumors, right, that are non-invasive, but the toxicity profile that you mentioned doesn't really behoove us to offer ERDA to patients with low-grade non-muscle invasive bladder cancer. But at the same time, there are studies and trials being developed looking at it in that patient population. What's your sense as to the role of ERDA in patients with low-grade non-muscle invasive bladder cancer? And I'll segue that then to a question to Dr. Kukeja. When do you discuss genomic testing with your patients that don't have metastatic disease? So Matt, you first.
Yeah, so I realized I didn't answer your question before about the timing of testing. So I generally test patients when they are diagnosed with metastatic disease because I want to have that information at least in the second-line treatment decision. And so that's usually when I send genomic testing. FGFR directed therapy for low-grade papillary tumors, I think you hit the high points. You hit the crux of the issue, which is that you have a target that's expressed at a very high frequency in a patient population that has a disease that's not necessarily threatening their life. And so do you subject someone to the side effects of a drug that has to be taken daily for that benefit? I haven't been involved in the studies with FGFR inhibitors in non-muscle invasive in high-grade non-muscle invasive disease, but what I can tell you from patients that I treat with metastatic disease who have tumor in the bladder, that tumor disappears just like their metastatic disease does.
And Dr. Kukreja, again, you can see here the Flatiron analyses of close to, more than 700 patients who were eligible for FGFR mutation testing showed then less than half of that had it actually performed. And then even when you had the results, less than half of those that actually had the mutation got the appropriate drug, right? So it's up to us as in medical oncologists, urologists, everyone to educate our patients about the appropriate time of testing. What's your practice at your center?
So I would say for non-muscle invasive, we're not routinely testing patients. I think, we are starting to do a little bit more testing in upper tract specifically. Because with the targeted agents and trials with that, I mean, usually I think just what Dr. Galsky described is most patients get cisplatin if they can get it. If they can't get it, then they get immunotherapy, and then once they kind of fail immunotherapy, they send it off for sequencing. I think what I have personally seen is I've had a couple of patients enter into the nivolumab period. So they got neoadjuvant chemo. They still had disease that qualified them for nivolumab, and now they have disease while they're on nivolumab, and they've developed disease then. And those patients are getting stuff sent off right away.
Question for you, Matt. I mean, this is your publications, what most of us cite, but could you summarize for the audience what makes a patient cisplatin ineligible?
So it's arbitrary. It's sort of a line in the sand, similar to well, maybe not so similar, but aligned with your work in terms of the need for harmonized decisions to inform clinical trials in the BCG unresponsive setting. To me, it doesn't so much matter that that definition is 100% right in every patient, but you need consistency or you can't do clinical trials. You have to define something before you can study it. So a patient who has poor renal function with an arbitrary cut point of a creatinine clearance of less than 60, cisplatin ineligible. Someone who has class 3 heart disease, cisplatin ineligible, performance status of 2, hearing loss, neuropathy. Those are the general criteria we think about.
And you were actually right with your initial statement. It is very similar to what we came up with the BCG unresponsive definition. It's not an all or none, but it's now hopefully a well enough defined group that we can do trials, make sense of it without needing a control arm, because the control arm would, ideally be a radical cystectomy. We have time for a few more questions. Let's see. I'll throw this up to both of you, really. What's your sense about using blood-based liquid biopsy versus tissue biopsies for testing versus, I guess, urine-based markers? Janet?
Yeah, I would say, there's a lot of companies out there looking at urine-based biomarkers. I would say nothing has stuck yet. I think, hopefully there's some stuff in the future where, patients can avoid, the morbidity of undergoing frequent cystoscopies and stuff like that. But I don't think there's anything today that I would recommend replacing cystoscopies with yet. As far as, and that's all urine-based. I have not really very much experience with blood-based stuff.
Okay, and Dr. Galsky?
Yeah, I mean, for me, this has been a little bit of a chicken and egg thing because if we needed FGFR mutation results to inform first-line metastatic treatment decisions, then it would be really nice to be able to send off blood because sometimes the block's in another pathology lab and you're calling that lab every day trying to get someone to cut the slides to send. So it can take weeks. So I think if we needed that information right away, then by all means having blood would be great. But as we've discussed, we don't actually need that data sometimes until the next line of treatment or 2 lines of treatment after that. And so we have the time right now. We actually had to close a study that was very similar to the North study, randomizing patients between immune checkpoint blockade plus or minus an FGFR inhibitor, actually the opposite, FGFR inhibitor plus or minus immune checkpoint blockade, because the patients couldn't be screened quickly enough to go on study. It was a frontline metastatic study. So in a study like that, blood-based testing would have been perfect. But I think it's this chicken and the egg that we don't need the information right away, so we're not getting it.
Great, thank you. We're right sort of on time. I want to thank everybody for your attention. I want to make another plug for the Bladder Cancer Advocacy Network. There's a lot of good information out on their website, including, a portal for patients to go in and then plug in information, look up clinical trials and see where they might be available. It's really important for us as a community to recognize that our patients, no matter whether they have metastatic disease or early stage bladder cancer, should really be thought of all the time in a multidisciplinary setting. I wouldn't necessarily want to send a patient of mine with low-grade bladder cancer first time to Dr. Galsky because I'll be wasting his time, but we need to think about these things, right? And when patients have metastatic disease, they sometimes are cured by Dr. Galsky's treatment, and then they start getting tumors in their bladder. And of course, then we have to see them back. So it clearly is a continuum for our patients, and it's really important that we support the multidisciplinary care for our questions. I want to thank all of you for your attention, for sending in all the questions as they were coming in. I addressed them as it were, try to keep it informal, and thank you for everybody at home as well. Have a good evening.